So I think we have about 10 minutes left for questions, so we did manage to preserve a bit of time for a few questions, and I wonder if there's anybody in the audience, and while you're thinking about it, maybe I'll just get started. The Twitter feed suggests that some people might be confused about the relationship between the conversation we just had and commercialization, so maybe we can explore that a little bit. My argument as it related to personalized medicine and the discussion from Sarah and Susan was that if you put the patient at the center and you get demand pull from the patient, maybe that's how the link is. But I wonder if either of you want to speak to the link between what you spoke about and the theme of the day in terms of commercialization.
I'll start by being very honest and saying that we had the exact same question. I think we all come from different perspectives and frameworks of looking at different aspects of healthcare. And I think quickly in our conversation that we had in preparation for this talk, we realized that commercialization is driven by the need, or at least should be driven by the need of products or services that are expected to improve health outcomes for patients ultimately. I mean, I think what's common among all the presentations we heard today is that it's a new drug or a new product that's aimed at improving outcomes and the health and quality of life of patients. And so the link with our talk, I think, is that to get the right products that patients want or feel they need to help them achieve optimal outcomes, that it's important to involve them in the conversation early on, from defining what a new innovation might be to planning how to evaluate it, to rolling it out to make sure that there's good adherence to the new innovation. So I think one thing we didn't talk about maybe today is it's great to come out with new products, but if patients don't use them, then they won't have the intended impact. In some areas, it's more obvious and more needed for life-sustaining measures, but in others, it's not. It's more prevention and the immediate benefit to patients. They might not see it right away. And so I think to maximize the investment that's put into new products, that involving patients early on in the discussion is key. I don't know if you want to add.
Okay. Catherine, I wonder, are there questions from the audience? Do you have one, Rick?
I do.
Oh, okay, great. I thought you were raising it. I thought that was to say I've got it to circulate.
I've got the microphone, and I'm not handing it out. So this is spectacular, and I'm posing this to Catherine and particularly Susan because you mentioned it. This 73% failure rate in implementation really resonates with me. We well know that. However, the recent synthesis that you talked about, the collective impact model, seems to me to be something that your measures, impact measures, Catherine, could relate to, because you've got 5 key conditions that have to be made. But more importantly, there are 3 mindset changes in that complex model that relate to who's involved, how people work together, and more importantly, how progress happens. Stage-based approaches. The collective impact model is the model we're using in ONF, in our Pan-Canadian spinal cord injury model. It's validated. The business model has been approved by Western Economic Diversification and the Ontario MRI. So the notion here is your thoughts on some harmonization across the matrix framework of collective impact, and what you're talking about in terms of the prospective approach to really capture the implementation stuff.
You're a tough act to follow, Rick. I think, you know, the really one of the important take-home messages for me, and it never hurts to keep being reminded of this from Diane and others, is the complexity of the system and the importance of the long-term view. These are enormous changes that we are trying to undertake. It requires huge amounts of energy and investment that is sustained over time. And so that long-term vision of making sure that we keep systematically working at this, we keep evaluating how we're doing in the process, not only the outcomes, but the process evaluation as well, is really going to be key to make sure that we don't become discouraged and dissuaded and look for the simplistic, low-hanging fruit answers that seem to be hardwired into many of our approaches to these challenges.
Yeah, I think working on shared measurement is more challenging than working on individual measures. So, also in regards to measurement, the keeping in mind, you know, the contribution that each organization are kind of bringing to the table. Work by John Main on contribution bundles, I think, fits in very nicely to this idea of the shared measurement. And then also, we have a tendency to use individual measures for shared activities. So I think we need alternative metrics or alt metrics for co-producing and co-generating, co-planning that is relatively emerging.
Which leads to building trust and a deeper understanding of each other. Yeah.
I'll just add we need new models for working together, too. And in my work, we've been funded by PCORI to look at some of these issues. And so one of the things we were asked to do was engage stakeholders and patients in ways that they had not been engaged previously, which was a real opportunity and really has been a delightful aspect of it. But it quickly became apparent that when you're working with a much more diverse group, you have a different understanding of how you're going to work together. So the way in which the healthcare professionals walk into the room and the mindset that they have and how they approach even identifying the questions is very different from many stakeholders, from our business colleagues, from patients, from family givers, and trying to understand how we are all going to work together more effectively, I think is going to be one of the new challenges that face us.
We've got at least two more. Well, we got about 4 questions, but we'll try to squeeze in a couple more. Judy?
Judy Ellis from the University of British Columbia. Thank you for a very interesting panel and also to a morning of very interesting sessions. I work in the space of ethical challenges around neuroscience discovery and neurotechnology discovery and translation. And we very much embrace the voice of patients and stakeholders in our work. But we find them to be unstable partners. And just as you would suggest, their experiences and their values and their preferences change over time, change over their disease processes. So how do we embody those shifts and those dynamics in patient-reported outcomes and also in some of the social licenses that we think about as we think about advancing our commercialization opportunities?
Tough question.
I'll just respond. I don't have any answers for you on that, although I've learned some incredibly important new things. One of the things that we hadn't anticipated when we began working with patients is the burden it places on them. And so as we've worked with patients for several years at a time, one of the things that we've learned is that we have to be very mindful of this because patients feel incredibly burdened by the notion of being the patient voice and representing all patients. So they say, I can talk about my own experience, but it feels like a big load on my shoulders to try and do it for the community of patients that's out there. That's one thing. And the other thing is that we've realized that we really have to be very thoughtful about the kinds of things that we ask them to engage in and not just bring them to the table as an equal partner because we're burning through them. It is an incredibly difficult and challenging process, incredibly rewarding, but very burdensome as well.
Anything else? Do you want to say something? No? Okay, so we're going to fit in a couple more questions and take the chair's prerogative of going slightly over time since we got a much later start. So, Alison.
So, Alison Buchan, University of Toronto, thank you for the panel this afternoon and also this morning. So I'm looking at the middle line of this, which is health, social, and economic benefit. And I think that really fits what you three have been talking about this afternoon. My question is going to really go to Catherine. Part of the challenge we have is different measurement systems. As Lapchi mentioned at lunchtime, the QS rankings just came out for universities. And U of T is really happy we're number 20, so we're in that top 20 group. But what they're looking at are bibliometrics, reputation of the university, student experience, and a very, very, very small piece, which is industrial funding. And the other big metric for universities is the Times Higher Ed, which is even more canted towards bibliometrics and citations. How do we square what universities are looking at with what we're looking at here, which is health and social benefits? They're not anywhere, as far as I can tell, in QS and Times Higher Ed, unless you want to say that social benefit is coming from the student experience. So there's this dynamic, and my sense is the CAHS model is more used by health funders in Canada than it is by the universities, because we're on different systems.
Yeah, it's a very good question. I would say originally when we chose to use CAHS, we chose it because it went across 5 broad impact categories, ending with health and social economic. And so we knew and had validated that the breadth provided balance to all our different stakeholder groups. And so the activities are quite intense resource-wise, and we took a comprehensive approach. 6 years in now, to your point, Alison, we're wondering, can we keep going on with this comprehensiveness, or is it time? And I think I'm saying it is time that we stop measuring so comprehensively and work together across our different groups and different incentive systems to agree, at least at a jurisdiction level, what success means to the province, and then kind of really force some decisions on those measures across. And then that will require us to talk across both sectors, but across institutions. So an example would be the harmonization initiative, which has kind of started a lot of those conversations.
So I think the short answer that I heard to this question, Alison, is VPs research need to start having breakfast with VPs academic to sort this problem out, because it really is that distinction between the research metrics that we funders and others use and the academic metrics, and somehow those two twains need to meet in our academic institution. So one really more quick question, Janice.
Janice in UBC, and this falls a little bit about the metrics. All of us now writing grants are now required to generally indicate your impact on policy and practice, and there's a checkbox, and very much either like this framework or other frameworks. Michael Smith also has the frameworks. My trainees are now also required to do this too. So we're seeing a greater use of the softer side. But I guess one of my concerns is in terms of the rigor of that, because what we see is, people who have engage one patient, one stakeholder, they check this, or if, what exactly types of policies have actually been changed, and then they tick this. And it tends to be, certainly working with my trainees, a much more liberal use. And so if that is going to be credible, I think there needs to be much more framework, and maybe is when you tick that, then it links to whatever policy or practice or things like that are happening. So I also think there needs to be much more training of us, because I see the agencies developing all these skills, but they haven't trained us or my trainees on how to use them. And I can tell you there is a very liberal use and training of whether we're having impact on policies and things like that. So I would just add that to that.
Mm. Anything to add, Catherine? I think my sense is that the good news is we've got the framework now.
Absolutely.
And people are using it.
Huge
The harder news is we really need to understand how to dig down and get good metrics for things like informed decision making. It's probably not enough, even in commercialization, to just add up the number of patents filed. This is not really an adequate approach. Catherine?
So to be brief, I totally agree with you. We've been building in quality assurance protocols, but we have to co-develop those better with the research community. We do want the evidence to be rigorous and credible, so totally agree. But we have to bring in new tools, new protocols for this, because a lot of it is self-report. And we are also starting to train in this area, so stay tuned.